Well, this is a population that, you know, historically, even though we don't cure the majority of them, we kind of approach them in a curative way. And Heather, I wanted to get your thoughts on the discussion you have in the point you try to make to the patient about chemoradiotherapy being curative and that sort of thing.
So that's a really key point, and even though we don't cure the majority, we do definitely cure some patients, and how that's framed is really important. And I think that one of the key things I always try to do when I'm talking to a bigger audience and to the patient, because many of them have been told before, this is stage 3, there's nothing that else can be done, here's some chemotherapy. I mean, there's still a lot of nihilism that's out there, even as we've had these amazing advances in what we're able to do to help our patients. So I talk with the patients about the fact that we are trying to cure. Inevitably, the question of surgery comes up, and even if the patient hasn't brought it up, we'll talk about why we're considering that patient wouldn't be a surgical candidate, assuming that it's a patient with 3B or 3A. We have a multidisciplinary tumor board, as I'm sure you all do. We meet every week, and our standard is that any patient with stage 3 disease is discussed there, so that the images are in front of radiation oncologists as well as surgeons and the medical oncologists, so we can all talk together to figure out what we think up front is the best approach. Back in the day, you know, that many of us were practicing back then. You know, the big question was when and should surgery ever be brought in? And for some of those approaches, we had the chemoradiation up front and then stop and go to surgery, and there was a risk that you would not be giving a definitive radiation course, and that break would be so long that then you had split course, which wasn't ideal. I think we've moved away from that, but we really do try to make sure up front we've decided this is a patient going to surgery, in which case they're not going to have radiation up front. Our group currently just isn't a big fan of that. I think that's a whole other topic for conversation.
That's a whole other program.
A whole other program. But you know, our kind of current plan is if they're going to surgery, we will consider doing upfront chemotherapy, neoadjuvant chemotherapy, and perhaps on trial with immune therapy, different question. But if they're not going to, then it's a definitive chemoradiation, depending on how long the timing's going to be. We often will give 1 cycle of chemo during the planning for the radiation, because that's going to take a week or 2, and we'll get into talking about Pacific later, but I think for some patients getting that extra cycle in can be potentially helpful if it's not going to delay the definitive start of radiation. So so I'll talk with the patients about it. It's a long course, it's going to be a rough 6 weeks, but our hope is to cure. We do have a lot of patients with EGFR mutations, ALK translocations, which we often do identify up front. And again, I think testing at that stage is a little bit controversial.
That's the next question I'm going to ask Paul. Coming up next.
So even in that setting, we talk about the definitive chemoradiation.
Right. Yeah. So Paul, now that Heather brought it up, you know, obviously molecular testing, broad-based testing in PD-L1 is an integral part of managing stage 4 disease, right? We don't quite know what to do with all that in stage 3, although to your point, it's often done. So you often know the information. What do you think should be done? And if stuff is done, does that cloud your judgment, or does that change your judgment?
Yeah, I think there are probably a couple of different ways to answer that. The first is from, I think, the most rigorous data-driven perspective. There really is no defined role for doing molecular testing insofar as we have no...
In stage 3.
In stage 3 disease, insofar as we have no guidance on the use of these targeted therapies in that context. PD-L1 testing, we'll talk about a little bit later when it comes to Pacific trial and some recent unplanned analyses when it comes to PD-L1 negative patients. So that I do find is useful to have. Yeah. I think the other way to answer this is from a practical perspective, which is that we know, as we discussed before, that a subset of these patients will have occult metastatic disease if we repeat PET imaging in a relatively short period of time. So these are patients who we will need this information on, and so ordering it up front makes a lot of sense, because then we don't have to wait, you know, for the results to come back. And in addition to that, I think, unfortunately, still a fair number of these patients will develop recurrent disease or, frankly, metastatic disease where we'll need this information. And just having it on hand without, again, having to wait or to rebiopsy offers a lot of, I think, power in terms of discussing and assuaging patients when that situation arises.
But would we all agree that in terms of with the diagnosis of an oncogenic driver in stage 3 disease, that currently we don't have any data to support targeted agents in that setting? Because this is a phone call I get twice a month. with a community oncologist who has tested, and they have an exon 19, and shouldn't I be giving them TKI versus chemo in this setting, right?
So there was a study completed in China that was presented at ESMO last year, where in patients who had stage 3 disease, who had known EGFR mutation, they did look at giving upfront EGFR TKI, and there's certainly been attempts at trying to bring that in with the chemoradiation approach. Unfortunately, the big cooperative group study in the US, which was identifying these patients up front and giving them erlotinib if they were EGFR or crizotinib if they had an ALK, in this sort of pre-chemo radiation setting, that unfortunately failed to accrue and had to be closed. So we don't really have an answer to that component. So there are questions, but it does come up, and there are occasional patients who are quite frail or who really understand that this is not curative, but it can be a little bit nuanced. And I practice in a place where half of my patients have EGFR mutations, so this comes up all the time. But yes, I completely agree with you that in a standard setting, if we have that information, it doesn't change what we do right then with the definitive curative approach.
Because for all we know, these patients actually might do better with chemoradiotherapy. Might. There is some suggestive data on that, but it's not clear.